Hello, my name's Amelia. I'm one of the physios on the Breathe programme, and today I'm going to be talking to you about medications for chronic respiratory disease. The aims of this presentation are for you to learn more about the different inhalers that you may use, to be able to recognise when to use each inhaler, and to learn more about the different medications that you may be on. Your doctor will decide with you which medications to use, depending on how severe your chronic respiratory disease is, how it affects your everyday life, and any side effects that you may experience. On the Breathe programme, we are physiotherapists, exercise physiologists and therapy assistants. We are not able to give you any medication or prescribe you any medication such as rescue packs. If any of these problems do occur, please get in touch with your GP. All patients on multiple medications or long-term medications are entitled to a medication review by an accredited pharmacist. This should occur yearly or whenever there is a change in symptoms or disease status. There are a variety of ways that medicine can be administered. I'm going to go over these in the next couple of slides. The main way, and what most people use, are inhalers. These act directly upon the lungs to treat symptoms, which reduces the side effects that you may see. They're easily transportable and quick to use. However, they do rely on good inhaler technique to deliver the medication correctly. Another way are through tablets and capsules. These are not routinely used and is an alternative to inhaled therapies. It allows through a slow release of medications through different mechanisms and can treat a variety of symptoms. Another way of administering medication are through nebulizers. These are a fine mist of medication that is inhaled through a mask, and they are often given for disabling breathlessness when medication has been optimised, and usually they are given under a respiratory consultant. They are used in hospitals for acute exacerbations, and they are a more passive treatment, which is less reliable on compliance and technique. Another way of delivering medications is intravenously. These are only used for those that are severely unwell, and they often require a hospital admission. We very rarely see these used in the community. Over the next couple of slides, we're going to go through the different types of inhalers. This is not an exhaustive list, and there may be other medications that you are on that aren't included. The first one is the metered dose inhaler. This uses a slow deep breath in to produce the medication, and they provide a puff of medication like an aerosol. They can be used with a spacer, which we will go on to talk about later on. Your inhaler will only help you if you use it correctly. Ask us if you don't know how to use your inhaler and we will be more than happy to show you. Examples of a metered dose inhaler are your Salamol and your salbutamol inhaler. Another type of inhaler is the dry powder inhaler. It is a fine powder that is patient pulled, which means that when you take the deep breath in, the medication is delivered, unlike a metered dose inhaler where you press the top of the medication or twist. It cannot be used with a spacer, which makes it difficult for some patients to use. Inhaler technique is very important. If you're not taking your inhalers properly, you may not be getting the medication that you need. Poor inhaler technique has been shown to increase your exacerbations and hospital admissions. There is a link below that shows you how to use your inhaler and the different types of inhaler that you may have. If you are unsure how to take your inhaler, please ask a member of staff and we will be more than happy to show you. It's very important that when you take your inhaler or you place it in a spacer device, that you shake it before use. Spacers are a very common device, and we see them both in the community and in the hospital. A spacer is a large empty device or tube that is usually made out of plastic. They attach to certain inhalers to optimise the amount of medication inhaled. They cannot be used with dry powder inhalers such as Trelegy. Without a spacer, about only 20 to 40% of the medication is delivered. However, with a spacer, this can increase by up to 20%. Spacers are useful if you struggle with inhaler technique, are very breathless, or when you are unwell. Some patients struggle to trigger the device or to take a deep breath in. If this is the case, please let us know, your GP or your pharmacist. To use your spacer properly, it's important that you shake your inhaler before placing it in the device. Attach your inhaler to one end and your mouthpiece or face mask should be at the other. Press your inhaler however many times you are prescribed and slowly breathe in and out about 5 to 6 breaths. If you're breathing too quickly or sharply, the device will whistle at you. Newer devices have a flow point, and this will show you if you're using it effectively. It's very important to clean your spacer as it prevents a buildup of residue. Soak weekly with water and washing up liquid, and complete more often if you are unwell. Rinse thoroughly and leave to dry naturally. Do not scrub or wipe, as this can damage the device. It's also important to not place your device in the dishwasher, as this can damage the mechanics. This image shows a variety of inhaler devices. Your device may be on this, but it is not an exhaustive list and does not show all inhalers. So, what do reliever inhalers do? They are short-acting, which means the medication lasts for about 4 to 6 hours. They work very quickly, with the Saber inhaler working about 15 minutes and the Samer inhaler working about 30 to 60 minutes to relieve that breathlessness. Your Saber inhaler, like your salbutamol, open up and widen your airways, and these relax the muscles in your lungs, whilst others, like your Samer inhaler, which is a Torvent, work by reversing the effects of those airways closing. They help with shortness of breath, wheeze, and/or a cough. Use 2 puffs up to 4 times a day as needed. If you are taking your inhaler more than 4 times a day, then please let us know. With Bricknell, more than 6 inhalations is concerning. However, your GP will let you know the parameters. Possible side effects of these inhalers are shaking and palpitations and muscle cramps. If you experience these, please discuss with your GP, as there may be other devices that they can use. Reliever inhalers are the most common inhaler device that we see. You may hear these referred to as a Saber, which is a short-acting beta agonist, or a Samer inhaler, which is a short-acting muscarinic antagonist. The most common medication delivered through these devices is salbutamol. This can also be called Ventolin, Salamol, or Aerolin. There is also Bricknell, which contains a medication called terbutaline, and we also have something called a Toravent, which has a medication called ipratropium bromide. So, what are preventer inhalers? These are inhalers that you take daily, usually up to 2 times per day, and they remain in your system for 5 to 12 hours. You will likely not feel the onset of them working. Dosage is prescribed based on your individual needs, and it can be taken up to 2 pounds per day. They help to keep your airways open and control symptoms. They reduce the breathlessness that you may experience over a longer period of time. They help long-term with lung function, and over 6 months have a significant improvement on lung function. They are not effective for a quick release of breathlessness, so it is important that you take these devices every single day. Possible side effects of these are dry mouth, urinary retention, dizziness, high heart rate. Remember, do not stop taking this medication even if you feel well. The next type of inhalers are preventer inhalers. These are things such as Braltus, Spiriva hand inhaler, Respimat, the Incruz ellipta, and the Seabree breeze inhaler.
The next type of inhaler is a combination inhaler. If you're having regular flare-ups of your condition or a change in status of your respiratory disease, you may be given this type of inhaler. They contain long-acting bronchodilators, which are an airway opener, with an inhaled corticosteroid, and this is a low dose of steroids. To be used twice daily, and you need to take these consistently to see best response. It can take up to 3 months to provide this best response. The main actions of a combination inhaler are they help reduce swelling and inflammation in your airways. They also help to relax the smooth muscle in your airway. They help to reduce exacerbations and flare-ups of your condition, and they can control symptoms to reduce breathlessness. However, they cannot be used to relieve symptoms or a quick attack of breathlessness. This is when you would need to use your blue inhaler or your MART therapy. They are used as a preventative inhaler primarily, and the possible side effects are a sore throat, palpitations, hoarseness, and tremors. To reduce the effects of a sore throat or a hoarse voice, please rinse your mouth out after taking your inhaler, as the steroids in these inhalers can cause people to get oral thrush. Examples of preventer combination inhalers are things such as the Symbicort Turbo Inhaler, the Foster, or the next inhaler. They can be in an MDI format or in a dry powder, the Revlor Ellipta, and the Durarest Spiromax.
MART is a new way that we are seeing reliever and preventer inhalers used in the community. MART stands for Maintenance and Reliever Inhaler Therapy. This is when combination inhalers are used instead of two separate reliever and preventer inhalers. We see it mostly in asthmatics, as it seems to have a massive reduction in airway inflammation, asthma symptoms, and flare-up and exacerbations. These patients will not have a blue reliever inhaler and will use their steroid inhaler to act in its place. This is mostly seen with a Foster inhaler, however it can be used with Symbicort as well. It can only be used with inhalers that have a specific medication in them called formoterol. Indications for this are taking all prescribed medications, but there's no improvement in your symptoms. You've tried add-on therapies and they're not having any improvement. Or if you struggle to take your inhalers already, such as issues with adherence or cognitive issues. If your GP thinks you would benefit from this type of therapy, they will place you on it. Please do not try this yourself at home. The last type of inhaler we're going to talk about are the triple combination inhalers. There are 3 different combination inhalers that are used in the community currently. Trelegy, which is a dry powder inhaler, Trimbo, which is a metered dose inhaler, and Truxeo, which is also a metered dose inhaler. These are used for moderate to severe COPD only, who are not adequately treated with steroid and preventer inhalers. It's usually given to those that are having frequent exacerbations and ill improvements in their symptoms. It uses a combination of low-dose inhaled corticosteroid and 2 long-acting bronchodilators, which reduce inflammation and keeps the airways open by various mechanisms. The type of inhaler you are on will be decided by your GP or consultant, depending on your symptoms and your amounts of flare-ups or exacerbations. They are used as a preventative inhaler only. Do not stop taking these even when you feel well. 2 key points are to rinse your mouth out after use, especially if you are finding it irritable, and Trimbo and Truxeo can be used in a spacer, which delivers the optimum amount of medication, especially if you struggle with your inhaler technique. Oxygen therapy is sometimes prescribed to those with very severe lung disease. Oxygen is a prescribed drug and therefore should only be started by your GP, consultant, or mostly your oxygen nurse. It is used for a variety of reasons, such as in long-term oxygen therapy, ambulatory oxygen therapy, or in an emergency, each coming with their different rules and regulations. People who may be using oxygen therapy for reasons such as chronic low oxygen, which is called hypoxia, or when they desaturate in their oxygen levels during exercise. If you are still smoking but require oxygen, you will be asked to stop smoking, whether this is cigarettes, vapes, or other uses. You can only be given oxygen when you have stopped smoking for more than 3 months. This is due to the fire risk that's associated when oxygen meets some sort of ignition, such as a cigarette. Generally, before being given oxygen, there are a variety of tests, such as blood gases, where a nurse will look at how much oxygen and CO2 is in your blood, and this will be done on 2 separate occasions before oxygen is given. They will also conduct an exercise test to establish how much oxygen you may be needing. Oxygen will not be prescribed for breathlessness alone, however, it may be prescribed in combination with chronic low oxygen. When using oxygen via the nose, you may experience a dry nose. It is important not to use Vaseline for this. Please speak to your GP and they will prescribe something that is safe in combination with oxygen. Nebulizers are not the first choice for long-term treatment. However, they can be used in the community on occasion. These devices turn medicine into a fine mist that you can breathe in. Most people don't need such a big dose and get as much benefit from normal inhalers as long as they use them correctly. High doses of nebulizers can lead to more side effects. They can be overused, which delays medical attention, and we always advise to use the inhaled route first. However, they can be used if COPD is severe, when it is not possible to activate the inhaler device, or when low doses from inhalers are not effective. It is important to not buy these things over the internet, as you are unsure if you are getting the right medication for you or if the device is correct. Another way of treating COPD is through tablets. These are called theophylline, or they can be called uniphylline or Phyllocontin. These help to keep airways open, and they are a form of a long-acting bronchodilator. You still need to take all your inhalers as prescribed, as this is not a steroid. Usually when taking these, we would advise to stick to the same brand if possible. They are a slow-release tablet to be taken as prescribed. Some side effects that you may see are nausea, shakiness, palpitations, and indigestion. Please let your GP know if your smoking status changes when taking these tablets, as it can change some of the properties of the medication and the dose that you may need. If you are struggling with phlegm, or to get up your phlegm from your chest, you may be prescribed something called carbocisteine. This has a variety of names: carbocisteine, mucodyne, and N-acetylcysteine. This reduces mucus thickness and stickiness within the lungs, and mucus becomes looser, which makes it easier to clear and cough up. It's not suitable for everyone, only if you have a chronic productive cough. It is often prescribed to those with productive chests and recurrent chest infections, such as those with bronchiectasis. Another capsule that we see used are steroids. The most common one that we will see is prednisolone. They can help treat flare-ups, however a small number of people may be on a low dose of these long term. You will most often find these in your rescue pack, and they can help to reduce the symptoms that you may experience when you're having an exacerbation. They help long term to reduce swelling and inflammation in your airways, and should be taken in the morning after food. Possible side effects of steroids are osteoporosis or brittle bones, weight gain, diabetes, skin thinning, and bruising. A key tablet used in those with chronic respiratory disease are bone protection tablets. These are for anyone on steroid tablets for more than 3 months, or who have lots of short courses of steroid treatment. These are called alendronate, which is Fosamax, Adcal, Calci-Chew, and they all contain different forms of vitamins that you may need to help your bones. If your GP thinks you're of high risk of having brittle bones or have osteopenia or osteoporosis, you may be prescribed a bone protection tablet. Some side effects of these are indigestion, and it's important if you experience any of these to get in touch with your GP. A medication we see used for those with interstitial lung disease or an ILD is an antifibrotic. Antifibrotics are given to around 50% of idiopathic pulmonary fibrosis patients, and this is ideally given when you are diagnosed and is stopped if the side effects begin to outweigh the burden of the disease. They are generally started by a respiratory consultant and they require special supervision. The two most common antifibrotics we see are nintedanib and pirfenidone. Nintedanib is an oral tablet which is taken once a day, and it is an antifibrotic that is used to slow down the progression of fibrotic changes. They are shown to slow down the decline in lung function and reduce the amount of exacerbations in ILD and IPF patients. Pirfenidone is an oral tablet that is an anti-inflammatory and antioxidant. It has been shown to slow down the decline in exercise tolerance, however, has some side effects. So if you experience some adverse side effects whilst on the drug, it is important to contact your prescriber. Another medication used in ILDs are immunosuppressants. They are used in interstitial lung diseases other than IPF, which is pulmonary fibrosis. This is generally the first line of treatment for ILDs, such as interstitial pneumonia and sarcoidosis. It is not used in patients with an IPF, pulmonary fibrosis, such as asbestosis. They require strict and close monitoring over 6 months and have different effects on the patient depending on the disease. Examples of these drugs include rituximab, and mycophenolate. Antibiotics are a widely used drug, especially those with a chronic respiratory disease. Antibiotics are a form of medication which is used to treat bacterial infections. Antibiotics do not work for viral infections, such as the colds, flus, and most coughs. When you are given antibiotics for your chest by your GP, they're usually designed to treat a broad amount of bacteria. It is very important when you start a regime of antibiotics and/or steroids, you complete the full course, even if you begin to feel better. If you do not finish your antibiotics, this can make them less useful as time goes on. Rescue packs are prescribed by your GP and are often started if you have recurrent chest infections or more than 3 in a year. They are a supply of standby medication to start if your COPD gets worse before you can see the GP. This may happen when you're on holiday or over a bank holiday. They are to be kept at home and to be used if you have symptoms of a chest infection. Always phone your GP practice if you have started the treatment. And always make sure that your rescue pack is replenished. If you begin to notice the signs of an exacerbation, it is important to start your rescue pack and notify your GP immediately, as you may need further antibiotics or steroids to help get rid of the exacerbation. There are specific criteria that each patient must meet before they are given a rescue pack. If your GP does not feel as though you would benefit from one, it is important to still get in touch if you feel like you are having a flare-up or an exacerbation. This image is an example of the asthma medication pathway. This shows the different steps that patients progress through with their disease and their medication. This is to show where you may be on one inhaler and another person in the group may be on a different one, as it all depends on the individual and the symptoms they are experiencing. Initially, when you are diagnosed with asthma, you may be prescribed a blue inhaler. This is called a SABA inhaler and could be Ventolin, Salamol, or Salbutamol. Through each step, it is crucial that patient education and environmental control are taken into account. And it is also very important to manage other comorbidities, such as any heart issues or anything similar. As each step progresses, this may signify whether you will be referred to a respiratory consultant or if they will continue to add on different therapies to help manage your condition and your symptoms. The best things you can do, aside from taking your medication, are to continue to exercise and make sure you are up to date with all your vaccinations. If you are managing well with your symptoms, your GP or consultant may try and step you down from the medication that you are on. Further to this, adherence to taking your medication is very important. If you do not take your medication as prescribed, this may lead to you being prescribed different medications to help manage your symptoms, and they may have higher doses of steroids or different therapies in them. If you have any questions about your asthma medication or whether you're on the right step, please get in touch with your GP or ask one of us. It's important to take into account different types of asthmas and how this will affect what stage of progression you are on. This image is an example of the COPD medication pathway. And is currently the gold standard.
Are diagnosed via spirometry.
Initially, an individual is diagnosed via spirometry,
and then the degree
which
of
is a form of
airflow
breathing
obstruction
test.
is obtained.
Following this,
After
an
this,
assessment of the
an
airflow
assessment of
obstruction is
your
obtained.
symptoms and your risk of
Alongside
exacerbations will be
this,
taken.
an assessment of symptoms and risk of exacerbations.
Depending on the number from your exacerbation.
All these factors help to decide what form of medication
This
is
image
most
is an
appropriate.
example of the COPD medication
Sometimes an
pathway.
individual may be asked to take their salbutamol
Initially,
inhaler after their
patients
breathing
are
test,
diagnosed via
and this will show
spirometry,
if there's any
which
signs
is
of
a breathing
inflammation
test.
reversibility.
And then the degree of
The
airflow
grade of your
obstruction is
condition may be
obtained.
determined by your spirometry,
After
but is also
this,
determined
an
in
assessment of
contribution
your
with your
symptoms
symptoms.
and your risk of exacerbations will be
If you are
taken.
having more than 2 moderate exacerbations a
Depending
year,
on the number
or at
from
least
your
one leading to
exacerbation.
hospital, you'll be placed in Group A,
This image
which is where
is
you're
an
considered
example
for a
of the
triple therapy
COPD
inhaler, such
medication
as
pathway.
Trimbo, Tralegy, or Trixato.
Initially, patients are diagnosed
If you're having
via
0
spirometry,
or 1 moderate
which is a
exacerbations a
breathing
year,
test,
not leading to
and then the
hospitalisation,
degree of
you may be
airflow
placed in the
obstruction
A
is
or B
obtained.
category. The A
After
category
this,
is just a
an assessment of
bronchodilator,
your
which is your blue
symptoms
inhaler,
and your risk of
and the B
exacerbations will be
category
taken.
is a mixture of protector inhalers, which will
Depending on
help
the number from
manage
your
your symptoms.
This image is an example of the COPD medication
Symptom
pathway.
management is a key way of deciding
Initially,
medications
patients are
and the
diagnosed
appropriate
via
add-on therapy for
spirometry,
each person.
which is a breathing test,
Only certain individuals
and
meet
then the degree
criteria for
of
what is
airflow
called add-on
obstruction is
therapy.
obtained.
This is the use of
After
unifilin
this,
or
an
nebulizers.
assessment of your
Depending
symptoms
on blood
and your
test
risk of
results,
exacerbations will
number
be
of
taken.
exacerbations, number of hospital
Depending on the number
admissions,
from your
spirometry outcomes, and the degree of breathlessness
This
will
image
determine
is an example
what
of the
stage of
COPD
medication that you are
medication
on.
pathway. Initially,
This is not
patients
the
are
be-all and end-all
diagnosed
for
via
everyone and
spirometry,
can change depending on
which
the
is a
person,
breathing
their
test,
symptoms, and any
and then
specific
the degree of
requirements they may
airflow
need.
obstruction is obtained.
The take-home message from this presentation are: your inhaler will only help you if you use it correctly, and it's important to keep taking your medication even when you feel well. Always take your inhalers and medication as prescribed by your GP, and it's important not to buy any medications over the internet. Inhalers and medications are not the only treatment for respiratory disease, and the best and most cost-effective treatments are giving up smoking, your annual flu injection, your pneumococcal injection, and pulmonary rehabilitation, which is us. Thank you for watching this video. If you have any further questions on your medication or want any further advice, please ask any member of the team, or for further information, visit the website below.